Good afternoon or good morning for some. My name is Iftamit, and I'm one of the board members of the Hospital in the Home Society Australasia. I would like to begin by acknowledging the traditional owners of the land on which we meet online today, each one of us from our own homes or workplaces. For me, this is the land of the Wurundjeri people of the Kulin Nation, and I pay my respect to the elders past and present. Today, we're fortunate to host this HITH Grand Round webinar on comprehensive care from acute inpatient to cancer care. We're joined by the Monash Health Adult HITH team, who will share their experience in providing integrated patient-centered care across multiple specialties. I encourage you all to participate by dropping your thoughts or questions in the chat. I'd also like to take a moment to thank everyone who made this event possible. That is our speakers, as well as, I do apologize, as well as all of you guys attending today and the HIF Society members whose support ensures we can continue hosting these educational sessions. If you are not yet a member of Society, now is a great time to join a growing community. Just scan the QR code and we'll be able to go into the login page. I'll just go back to where we were. So just in the QR code and you can just sign up. Now, also, if you'd like to help with organizing future Grand Round session, as currently it's just myself doing it, please reach out on the following email address, which is just here. So just my name, so ifta.amit@hitsociety.org.au. Very happy if you can just send me an email and we can go from there. Before we begin, a quick reminder that our speakers' views are their own and do not necessarily present the official position of the HIF Society Australasia. Likewise, any opinion I share today are entirely my own. So let's get started with our first presentation. Over to you, Dr. Jun Song, Medical Director, Hospital in the Home at Monash Health.
Good morning or good afternoon, everyone. I do apologise for the lack of my face due to interface quality issues. I promise I will briefly show my face at the end of my talk, so at least you can put face to my talk. So I guess rumour has it, Monash runs one of the biggest adult HITH service in town, and we have been very fortunate to be visited by a number of our colleagues in Victoria in the HITH space. So therefore, I've brought with me a team of very capable and skilled doctors and nurses to either confirm the rumour or to demystify Monash Health Adult HITH for you. Next slide, Helen. And IFTA has done a thorough acknowledgement of the traditional owners. So I will go to my next page. So without further ado, I will give you a quick service overview. I'm the Adult HITH Unit Director, and Helen Richards, who is our Director of Clinical Operations, will speak to you about our workforce and our journey so far. We are very fortunate to have a cancer at home service. So our service leads, therefore, our haematologist, oncologist, and Fiona, who is our medical director for palliative care at Monash, will speak to you in length about our cancer arm. And last but not the least, Associate Professor Ben leads a very active research group within Adult HITH and as well as a big ID services within HITH. Next slide, Helen. Next slide. So I am mindful that the audience here, not everyone is in Victoria. I guess in Victoria, our definition of HITH is an acute bed-based admission substitution service, and we do outpatient activity for cancer-related services. I guess how do I know, or how do our clinicians know if a patient will be suitable? So a patient ideally needs to be admitted to a patient bed in an acute bed for their care. They need to be safe to be cared for in the home, either by themselves or somebody else as a carer for 24 hours per day. And their care need to be met with a maximum 2 visits per day, a maximum of 1.5. Helen, if you can go back to the slide. Thank you. Yes.
Sorry.
Yeah, 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 and then patient will need ongoing medical governance by Monash Health. How are we funded? I guess them as inpatient services, inpatient and well, and for our outpatient cancer services will be outpatient and well. We do have a partnership, strong partnership with our primary units for funding arrangements. And for those of you who are not familiar with Victoria or Monash Health, we are a large health service. We do have a number of hospital sites, with Monash Medical Centre being our mothership. And we also have Victorian Heart Hospital. So therefore, I guess Adult HITH isn't the only HITH service at Monash. We do have a separate Monash Children's at Home, a maternity home, a mental health HITH, and as well as a gem at home as well, which sits outside of Adult HITH. Next slide, Helen. I guess just a quick overview of our adult HITH patient cohorts. Like traditional HITH, we do a number of medical conditions and surgical conditions, which include infections, anticoagulation, complex wound management, drain management. We do some other direct patient pathways for surgical patients, and bed substitution for our GenMed cohort for clinical monitoring or coordination of services. Because we do have a large number of subspecialties within the service, we do support a number of chronic conditions for patients in the respiratory, cardiac, and liver failure patients. And lastly, we do have a fairly comprehensive cancer care group where we do oncology, haematology, and also palliative care. Most of our care is inpatient, hence multi-day stay, but some are same day for a number of our infusions to support our inpatient complex cohort, and as well as outpatient, again, to support our cancer care. Next slide, Helen. Again, just another visual presentation of the medical conditions that we manage. Traditional HITH cohorts also include some covert early therapies that we do. Next. And a quick service profile. So we're approximately 155 beds. As you can see, there's sort of a divide between different sites. We have Dandenong Clayton Medical Centre is our biggest site. Our workforce, we do have medical nursing, allied health, pharmacy, and administration. And we certainly broker services if we need to. Our nurses are on the road from 7 o'clock in the morning till 9:30 at night, and we run clinics every day of the week. And that's in a nutshell our service structure. And I will hand over the talk to Helen, and I just quickly show my face so you know what I look like. And
You haven't come up, June, or is it just me?
okay, all right.
It's all right.
Yeah.
And I'm the one that can't run the computer, so I apologize. So I'm the Director of Clinical Operations. So I'm the nurse responsible for the oversight of all 4 sites within our HITH service. So our workforce is, from a nursing point of view, broken up into 2 segments. So Clayton and Moorabbin is one, and Dandenong and Casey is the other. And each hospital has a very different mix of patients, and our nursing staff move between the 2 sites so that they're constantly having contact with different cohorts, because we do see a lot of people, and we try and see the patients not from the hospital they were referred from, but the one that is closer to their home if we're going into their home. And that's just a logistical thing to make as efficient as we can be. We have our own GenMed unit where our structure is like any other GenMed unit. We have consultants, registrars, residents, and they see across all 4 sites. And we have an advanced trainee and general medical residents are our senior juniors, if that makes sense, and there's second and third year RMOs that come through. We also have 3 pharmacists, an amazing dietitian, and we have access to home visiting physio and OT as we need it through a brokered service. Our nurses, we are very particular about who we employ, and for us, it's really important that we have experienced, highly trained nurses that are able to manage a significant level of complexity with confidence in a home environment. All of our nurses have to have had at least 5 years experience, and we do a 4-week orientation program with them. We have 2 nurse educators that support our almost 100 EFT of nurses, and our orientation is a mixture of learning and hands-on experience, depending on what the nurse's previous clinical experience was, depends on where we focus. So it's about making sure that they feel comfortable with such a range of patients, and all of our nurses are trained to be able to provide cancer care. We have a nurse practitioner in cancer care as well who helps support not only our patients that we see, and we see a lot, it's about 40% of our work, but also to support the nursing staff when they need an expert to advise them on what's the right thing to do from there on. We also every year offer a training day that we pay for our staff to go to get annual updates. Our pharmacy, where are we going? Our pharmacy service, I think like everybody, we could do with probably another 5, but the 3 that we have 3 very distinct roles. Antimicrobial therapy for all of our infuser bottles, anti-cancer, which are responsible for all the compounding and helping us with our subcut chemos, ensuring that we're giving the right thing to the right person at the right time and that they've had the right investigations to be safe. And then our complex care and palliative pharmacist, which is everything that doesn't sit in the previous 2 buckets. Not all of our patients, like everybody who runs a HITH service, not all of our patients need pharmacy input, but with a high number of cancer patients, we do have quite a significant burden on them. And our journey so far, so I've been at Monash for 12 years, and when I started, we had 60 beds. We have gone up as high as 180 beds previously, but we're currently at 155 because we're being fiscally responsible. And we are within 10% of usage every day. We are also a very cost-effective service. So for running our 155 beds, for everything except for our pharmacy costs, it only costs us $12.5 million a year. So our per bed day cost sits between the 300 and 400, depending on the month and the patients that we're seeing at that particular time. But we are cheap and cheerful compared to an inpatient bed, which in a time where money is tight, which everybody has, makes us very attractive as an alternative, as a sort of release valve for high demands on the service. And Monash Health for this financial year is over 105% of our NWOW. So being over target means we're now doing work for no money, and that makes us even more attractive. How we're funded internally is on a per bed day basis, and we've had that in place for about 9 years now, and that has been a game changer. One of the barriers that we found when we were trying to develop our service was that the primary units didn't want to give up the activity because, the money goes to the primary unit, and that's how they go, look at us, we're fantastic, we're doing what we need to be doing. And so we actually negotiated that we don't have an NWOW target as such, we have a bed day target, and that the NWOW goes to primary unit. So they get work without having to do work. And that was a huge game changer for us to get engagement from, especially surgical units. Let's be honest, the surgeons don't want to give up their money. No offense to any surgeons that are on. And we have, since 2012, developed our cancer care cohort. We started with one patient, as everybody does, and that was part of a telemed grant that we got from the department way back when. And we now have a very extensive cancer care model that includes oncology, haematology, and supportive care, which is sort of like a type of palliative care, which I will allow the experts to talk about. But it is a group of patients that challenge us, that reward us, and a lot of our palliative end patients we have actually provided care for previously. So there's that lovely continuity of care for the families and for the patients themselves. And I will hand over to Ben.
G'day, thanks so much, Esther, Helen, and June, and the whole HITH team. So I'm just going to talk briefly about the HITH ID service. I'm giving this piece for Lydia Upjohn, who's kind of the heart and soul of our HITH ID service, but unfortunately can't be here today. And I can, as all of you know, really, hospital in the home started as infectious diseases. And it's amazing that it's now branched out to all these other things, and we make up a smaller component of HITH than we used to, but still an important component at Monash. I guess there's a few things about our structure maybe that we're fortunate to have that are a little bit unique. One of which is that we run an in-house specialist model where the ID physicians are kind of employed by the HITH service and work sessions for the HITH service in addition to the sessions for the clinical ID service. That's been very advantageous for us because we kind of have a dedicated staff with a concentrated expertise. And I guess if I was to highlight any disadvantages, it would be that there's a bit of a transfer of care as patients move from the inpatient ID teams to the HITH ID team. And there's maybe been, I didn't want to say de-skilling, but I guess it's easier for the inpatient teams to be a bit less skilled in delivering HITH or OPAT care because, there's a group of us that kind of do it all the time. To deliver our ID service, we, do weekly face-to-face reviews of all patients under ID HITH program. And we try to have continuity with the same specialist seeing them each week. We have 10 clinics across 3 sites where we run our ID service, and we typically see 30 to 65 patients a week across those clinics and sites. So that gives you an idea of our ID load, and that's complicated ID patients. That's not cellulitis, that's our endocarditis, our bone and joint infections, our immunocompromised patients, and so on. We also run a layer of care coordination above that. We have a structured handover plan on transfer from the ward that the ward ID teams complete with an outline of what they'd like. And we run a weekly infectious disease MDT at each of the sites, which is a multidisciplinary meeting where we review each patient and their progress and also their treatment plan and look at whether we can shorten their treatment, change their treatment from IV to oral therapy, or whether there's any indication that they're failing treatment and need some kind of further review. We also have a dedicated diabetic foot podiatry ID meeting, which is separate from our other meetings because we identified that we needed some other specialties there, including the podiatrists and the endocrinologists. If you just click on a little bit, I think there's a list of us there, but that doesn't matter. They're just the ID specialists in the program, and we each bring different skills to the program, which has been really helpful. We work in different parts of ID within the health service, so we really bring them to the program. One more slide, I think. And I think, thinking about our model and how fortunate we are to have it, there's a couple of real advantages. One of which is with the inboard ID service, we've been able to get the referring units really to have confidence in us. So we're getting, I guess, earlier referrals and transfers of patients than we have historically. We're comfortable taking patients with Staph aureus bacteremia or other conditions, for instance, before they've had a transesophageal echo, and we'll facilitate that on the HITH program and then can modify the treatment plan based on these findings. Similar for bone and joint or spinal infection, we're comfortable for patients if they're stable before they have an MRI. Surgical patients are the same, and also patients that might have, ongoing kind of abnormalities that need monitoring. And that's really because, all patients are going to have consultant eyes on them at least twice a week, during their clinical review and during their MDT, plus more often if required. We really try and look at flexibility in antimicrobial route and duration. As many of you know, we're now really pushing towards more oral therapy and less IV therapy in complicated infections. And our preferred plan that comes from our ward team now is something along the lines of, this is what we want to do, but these are the criteria we're happy for you to use to switch to oral therapy. So a lot of our patients come to HITH now without a fixed duration of therapy. The worst plan we get is that this patient needs 6 weeks of IV therapy. Our preference is to get something like, this patient needs a minimum of 2 weeks, and we're happy for you to put them on orals when they meet these criteria. And sometimes there's a bit of liaison back and forth with the other teams to make sure we're all happy, but that's how we try and operate. We also have a bit of comfort with less frequent infections given the high caseload, things like liposomal amphotericin at home, treatments for drug-resistant CMV, some of our newer antibiotics for extensively drug-resistant organisms. And also with the multifaceted HITH program, we do a bit of co-treatment where we have patients receiving haematology care and ID care on the program, for instance. And also there's a bit of leverage of research, which I'll talk about at the end of this presentation. And I think that's all I've got to say about it.
Fiona.
Thanks, everyone. I'm Fiona Runacres, a palliative medicine specialist here at Monash, and have the privilege to work within the HITH unit for the last couple of years, and have recently handed that baton on to Beverly Sue, who's joining our meeting today. So just to give a brief overview of the evolution of HITH palliative care. So this collaboration first commenced going back 8 years to 2017, coming out of cancer pain management. We know a lot of patients are desperate to spend as much time as possible in their home setting, but when they were trapped in hospital for complex pain, opioid titration, or rotating maybe from an infusion onto oral analgesics, that was sometimes delaying patients being stable enough to be discharged home from hospital. So HITH stepped into this gap really as acute bed substitution. And they're able, through 2 nursing visits a day, working with palliative medicine specialists, able to titrate patients' opioids and make sure that they're safe from a toxicity perspective too. So we've done complex cancer pain titrations of methadone and infusions and orals and patches and all of that rotation at home, which traditionally would have always needed the safety net of being in a bed-based inpatient setting. And then slightly more recently, we've had the evolution of our patients needing recurrent drainage of ascites or pleural effusions, and using indwelling peritoneal or pleural catheters to really effectively drain modest or moderate amounts more frequently than traditionally if they were coming into hospital every 2 weeks or 4 weeks to have large volumes drained. So this again has enabled patients to be spending time at home, but having really great symptom management because of that, maybe second daily or even up to daily drainage of their effusions. And these aren't just cancer patients. We stepped into this space in the cancer setting, but we've increasingly had patients with advanced liver disease, cardiac failure, really benefit and have less time in traditional hospital settings being under the HITH program. And then our more recent innovation in HITH palliative care has been stepping in to be able to deliver continuous subcutaneous infusions of palliative care medications. So for these patients, perhaps they're not already known to existing community palliative care services, but again are desperate to be at home. So HITH has stepped into this space of being able to continue 24-hour continuous subcutaneous infusions until they can be appropriately linked into their relevant community palliative care service. So people associate this with patients approaching their end of life, but it's also patients with maybe malignant bowel obstruction who just need that subcutaneous delivery for effectiveness. Thanks, Helen. And because these patients are diverse in terms of their diagnosis, their goals of care, their their prognosis, we really, really need our whole multidisciplinary HITH team, including doctors, nurses, allied health. We have a weekly MDT where we invite staff reps from relevant community palliative care services if patients are benefiting from some HITH intervention, whilst also under the radar of community palliative care service. So we do really shared care there. And we engage, this is one of the beauties of working in HITH, the ability to work collaboratively with so many other specialty units. So we also provide palliative care consult for other HITH patients who might be on the program for IV antis or complex wound care and also have palliative care needs, and work really closely with our other medical specialist colleagues. And as Ben touched on, next slide, thanks Helen, we're keen to disseminate our experience, our learnings. You'll see a few papers, and I can see that Phil's also put in the chat that our HITH palliative care model is going to be presented at the World Hospital at Home conference later this year. So thanks for the opportunity to explain our HITH pal care program.
Thanks,
I'll pass on to Amy and Charla.
Thanks, Fiona.
Thanks, Fiona. I think Amy might.
I'll start and pass over to Charla section. So just introducing both of us. My name's Amy Boddy. I'm a oncologist here at Monash Health. And
You're really quiet, Amy.
Oh, sorry. I'll try and shout. Is that better?
That's better.
Okay. I'm an oncologist here at Monash Health. My name's Amy Boddy, and I work point 1 in the HITH service as well, overseeing our HITH oncology patients. As you can see here, between haematology and oncology, there's a huge number of visits facilitated by HITH annually. So this is just a snapshot from up until November last year. And you can see there that we had a total of about 5,500 visits facilitated by HITH during the year. Next slide, please. So just breaking that down between oncology and haematology and what those visits are actually for. The main categories of visit for patients having their anti-cancer therapy. So those patients are receiving either chemotherapy infusions or subcutaneous injections for their anti-cancer therapy that they would normally have to attend a chemotherapy day unit to receive. Then some patients have their chemotherapy connected in the chemo day unit, but have that infusion for 2 days or 5 days, and then hospital in the home is able to disconnect their infusion and dispose of the cytotoxic equipment, saving the patient from a second trip back to the hospital. In terms of our workload, that's our key workload. And then we do also have some longer admissions, which Charla will talk to in a second, for haematology and for oncology. So over the course of the year, we also had about 100 patients who had multi-day admissions, which are more bed substitution admissions. And those patients in oncology are typically patients for symptom management, and for haematology are for close clinical monitoring. Next slide. This is our drug portfolio of drugs that we currently deliver through the HITH service. So both of our units can deliver zoledronic acid for malignant indications and also for malignant hypercalcemia. And then we have a number of targeted therapies and also chemotherapies, which are available through the hospital in the home service. So typically these drugs in a routine setting would always be given in a chemotherapy day unit. So this is essentially saving patients a trip to the hospital and freeing up that space for more complex therapies to be done in the day unit, where perhaps there's a risk of anaphylaxis and they need that monitoring. It increases our day unit capacity. Thank you. Next one. So I'll let Charla speak to the AML at Home program.
Thanks, Amy. Thanks, Helen. So I'll start with the AML at Home program. So I guess firstly, haematology care has really expanded in hospital and the home. And these patients, like the oncology patients, just have to remember they're high acuity, they're complex, and the treating teams like the hematologists and oncologists have a very close, sorry about that, I might wait till the, have a very close association and link with their patients and very protective. And these patients are very complex. So it's been really wonderful that we've been able to expand this service. So I'll talk to the AML at Home program. And this was a part of the Better at Home initiative from the Victorian government, particularly around the time of COVID, to get patients out of hospital and to be treated at home. So it was developing this program took some while in terms of figuring out the safest patient cohorts to be treated at home. And so this is an overview that I have here. So we have 10 dedicated beds, so 10 cancer care at home beds for these patients. We have our nursing staff, whom Helen has described quite extensively, and they're excellent, and they're all ADAC trained or chemotherapy trained, and familiar with all the chemotherapy protocols on EviQ. We have extensive pharmacy and allied health service, as well as clinical nurse educators. Next slide, Helen, please. Thank you. I know this is a bit of a busy slide, but the objective of this program was to provide this hybrid model of care. So patients with requiring high intensity chemotherapy and patients who essentially would otherwise have at least a minimum of a 20-day stay in hospital. And it was the cohorts of patients that we have in this program are elderly AML. So patients unfit for induction chemotherapy, which is intense chemotherapy, who are receiving a step-down treatment as standard of care, who are actually monitored till pretty much, so it's through their neutropenic phase at home till neutrophil recovery, where they would otherwise have been in hospital. And you have to remember, we now have a globally aging demographic, and we have increasing number of patients being diagnosed, and otherwise fit and well patients who we otherwise probably wouldn't have treated previously. We have the younger cohort, so the fit AML or ALL, so young patients with leukemia who have their intense therapy. Because they're going to be in hospital for a minimum of 30 days sometimes, we get them home prior to their neutropenic phase, and then readmit them electively. Other patients getting other types of intense chemotherapy, again, for other types of lymphoma. And our newest cohort is autologous stem cell transplant for either multiple myeloma or certain types of non-Hodgkin lymphoma, where we are basically monitoring them again till their neutropenic phase, and they're admitted electively. So how the model works is that these patients are monitored at home. They're seen twice a day at home by the nurses. Bloods are taken in the morning, and a virtual ward round is done with these patients by the home team. So it's almost like a shared care. I mean, the patients are still actually under the hematology bed card. So we have oversight of their care. They are monitored. They've done a telehealth ward round, and any changes are documented on EMR. And therefore, the nurses have visibility of what's happening, and there's sort of ease in terms of communication. And then again, they're readmitted electively in their neutropenic phase, or if there's a concern from a nurse who then escalates it to one of the hematology team, and we have a escalation procedure, which I haven't put here. And one of the, I guess, the important feedback that we got from consumer feedback that we got before we started the program was readmitting these patients, because these patients have a bed, they have a single bed on the ward that they don't want to lose. And most patients, nobody really wants to have to go through emergency again to sit there for hours to then wait to get back to the ward. So we were able to get this contracted care bed agreement with a private hospital that's co-located with Monash Health only in Clayton. And so that bed is available to us 365 days of the year. We have one bed where we can get a well patient from our hematology ward onto that ward, and we get our unwell patient or AML at home patient straight up to our heme onc ward. Next slide, please, Helen. Emmy, would you like to speak to this one?
I think your sound's better, Shala, so go for it.
Oh, okay. All right. So I think we have and this is a new role and a role that I haven't been familiar with, and it's been a fantastic addition to I think the heme onc palliative care service is our cancer nurse practitioner. She's a dedicated senior onc heme nurse, and she provides extensive support to all the cohorts. She's able to, as part of our escalation procedure, nurses on the ground will be able to escalate any concerns to her. She's able to counsel on management. She's also able to discuss other ancillary cancer care related issues, as well as the fact that she's got very close she works closely with, from a heme side of things, we have our lymphoma nurse coordinator, as well as the senior oncology nurses, and as well as the team, so both teams, hematology and oncology, to provide very sort of comprehensive oversight of patients' care. So there isn't a reflex where the patients are just sent to emergency. They're only sent when they're really required. Next slide, please, Helen. I think, well, this is the next slide. Yeah. So I think, look, there are a lot of benefits, and we've seen that, and we haven't put into publication yet. But one, of course, is patient-focused care. And I think this program of treating these patients at home has really empowered patients. It's improved their mental well-being, their sleep, and patient-related outcome measures are going to be measured. And the important thing is for these patients as well, they know that there is always hematology, oncology, medical oversight of their care. And another important point, I think, is care fatigue, because these patients are in hospital for a minimum 2 weeks, and it can be quite a strain on patients, especially with, patients, older patients with younger, children with young families who have to make time to come in. And so the other one, of course, is hospital performance indicators, the financial costs. So there is a lot of, we've had just a brief snapshot of just the AML at home cohort. So for the 2 years that we've been running, we've had about 40 admissions, and we've saved probably over 500 bed days where these patients otherwise would have been in hospital. And yes, it's a flexible system. We can expand or reduce with demand depending on, the circumstances of the time. Thank you, Helen. And Amy, I'll hand it back to you.
Thanks. So I guess I just wanted to talk a little bit about scope for growth in the future. And I think this is just an ongoing challenge in every aspect of cancer care, where we have an aging population, increased indications for cancer treatment, more tolerable cancer treatments, and more effective cancer treatments that potentially keep people alive for a very long time. So just looking at potential for the future, at the moment, we deliver nivolumab at home, which is a PD-1 inhibitor therapy. There are a lot of other drugs in that drug class which we would be able to deliver at home if resources allowed. But at the moment, the amount of workload that would be about 50% of our existing workload again, so expanding our capacity to 150%. And so there's a huge scope for growth here, and I think this is an evolving field in cancer medicine. One thing I think June didn't mention in her introduction to our service is that we're quite a geographically large service. So our patients who we are the local cancer centre for may potentially be travelling for 1 hour's drive to come to our centre, even though it's all within southeastern metropolitan Melbourne. So being able to deliver treatment at home is a huge time saving for patients and a cost saving for them as well, in terms of taxis, petrol, parking, all of the things they have to pay for to come and see us in person. So there is huge scope for growth, but obviously also with the highly skilled workforce required at the moment, is something we're just gradually assessing, gradually scaling up in a sustainable, safe way. So I think this is a real watch this space, and hopefully next meeting we'll have more updates for you in terms of where our service has grown to. Thanks.
G'day, thanks so much. I'm back again. I've only just got a few slides, and then I think there's plenty of time for discussion, which everybody will be keen on. Actually, if you can just pop back one, thanks. So, I think you've heard about the kind of the size and the scale of our HITH program. And, one of the things that we feel has been really important with this program is, leveraging some research off it, really thinking about what we do and why we do it and how we can really improve HITH care, not just for our site, but, for other places in Australia as well. And that's pretty much what we've tried to do. One of the things that was kind of a criticism of our program when we started, or when I started, was that we did a lot of stuff and nobody quite knew what we did. We were a bit of a black box. So one of the things we've tried to focus on really has just been descriptive cohorts to some extent, really just looking at some of the cohorts we manage and understanding how we manage them, and the good and the bad of that. And we've got kind of publications looking at who's readmitted from our program back to hospital and what the risk factors are. We've got a study looking at heart failure, actually, which turned out to be more a study of why people don't make it to HITH with heart failure, which has been a very useful piece of work for us. You've heard about some of the palliative care work, and there's some work with our hepatologist on liver disease, which is really fantastic. Personally, I look at antimicrobial therapy, and we've really looked at a number of ways to optimize our use of antimicrobial therapy kind of on the HITH program, including for ESBLs and resistant infections. We've recently looked at antifungal therapy and how we use that on the program, streptococcal infections, and we've got something coming on enterococcal infections as well. These things all feel a little bit boutique on their own, but I guess the idea is really to build a picture of what we do and why and how we do it. We've got another stream of research running on model of care work and service delivery. We're looking at oral switch work and, the best ways to support patients when they're going from IV to oral therapy. We've got Sophie, our dietitian, looking at stuff around allied health, and I think a number of you have been engaged in that as well. And we're also looking specifically at some of our really high morbidity conditions like endocarditis and our model of care around that. We've got a couple of collaborations where hopefully we'll be looking at some, new devices, point of care tests in HITH. I'm involved in a program which is an interdisciplinary program trying to develop a device that will help HITH antimicrobial delivery. And we've got another interdisciplinary program looking at the impacts of climate change on HITH. And I think the real thing about our research is, we really try to look for questions that are really interesting and relevant, are going to give tangible, benefits from the outcomes. It's very interdisciplinary, which is great. There's no point having a research program if it only involves one stream. We try to have allied health, pharmacy, nursing, junior and senior medical staff, and sometimes students involved. We try to incorporate our research into day-to-day practice, and we're very grateful to the HITH staff that support this, where they may need to collect a little bit of extra data or do a little bit of extra work at some stages with the patients that are within research programs. And we really try to collaborate broadly within our health service, across to our academic university campus, and nationally, internationally. And I think really it's fair to say we've got a whole lot more to do. Just one more slide there. We've had a lot of really good outputs. I think we've had some nice publications. We've had a lot of conference and poster presentations, which for me are really good because they get to the people, who really need to know this information. We get to chat and talk about it, and it's been fantastic. And we've had one of our projects, which is this cooled antimicrobial delivery, also received some Premier's Good Design Awards in 2024. So, I think we love to do this. And aside from anything else, if you are interested in this, don't hesitate to reach out to us about, collaboration.
Excellent. Thank you so much, the Monash team. Really fantastic presentation from all of you guys. For the people attending, please put in your questions in the chat. There's some questions that we can go over. I can see that some have already been answered. Those will be nice if there's anything to be elaborated on. So the main one was, I can see, is keen to know the grade and classification of the nurses in Monash Health, which I think is very topical.
Yes, so our direct delivery staff are 3Bs. In Victoria, under our award, there's a classification for the nurse in charge, which is a 4A, and the direct care staff, which are 3Bs, and our nurse practitioner is paid as a nurse practitioner. And that's all very much mandated under our EA.
Fantastic, thank you. The next question we had was regards to a geriatrician in the Heath medical workforce, in which I can see there were some answers in regards to the current structure. June, would you like to elaborate on how it is currently done at Monash?
We do have an in-house geriatrician, so I guess who does help us for our complex cohorts, who do help us to set the goals of care, having some very difficult conversations with our families and for an ongoing journey for those patients who do stay in the service for a prolonged period of time. I think a number of us did touch on just the sheer size and the catchment of Monash Health. So we are very fortunate to have a dedicated gem at home. At Monash, we call them Monash at Home ARC, and also a dedicated residential in-reach service, which Helen also provides leadership for the nursing aspect. So feel free to chime in. So we do work closely with them, and sometimes there are some overlap cohorts, especially with the residential in-reach cohorts.
Fantastic. And what about our patients that do require emergency geriatric care but are not in nursing homes?
One of our HITH consultants is a geriatrician. So he takes sort of the lead in supporting those patients.
Fantastic, thank you. There is a comment regards to it's possible to obtain copies of the slides. That's up to the Monash team. If they send to me, I'm happy to distribute. So just send me an email and I can send it to anyone who reaches out to myself with the initial email address that we had before. For those who missed it, just this one. And again, I will repeat as well, if anyone wants to be part of organizing the grand rounds, please reach out to me as well on this email inbox, as well as become a member of the HITH Society if you're not already a member. What else have we got? Are all the HITH chemo visits at home or a mix of home and clinic? And if so, what is the split?
We might answer separately for oncology and
Yeah,
haematology because I think
yeah.
it's different. So for oncology, we have a rule that usually the first 3 infusions need to be in the clinic. So if there's a person's likely to have a severe adverse reaction, that it's observed in the first few doses. Most of our solid tumor oncology patients then transition to have all of their treatment in the home. The exception to that would be patients who are on a regimen that alternates between a more complex regimen with multiple drugs and a simple single drug regimen. So some patients might have 2 immunotherapy drugs one cycle and 1 the next cycle. Those patients would alternate between hospital and the home and the day unit. But for oncology patients, it's fairly simple. Once they're on HITH, they can stay on HITH unless their clinical condition changes.
Thanks, Amy. So thank you. So for the heme patients, it's similar, but we just need the first dose given in a hospital-based setting. So that might either be on the ward when they're admitted or in a ambulatory care. So we have a medical infusion unit or our day treatment center, but all subsequent doses, even for that particular cycle, can be delivered through a hospital in the home. So they're mainly essentially after the first dose, they're home visits. and that includes the AML at home patients. So they use those patients. I might actually answer. There's a question in the chat because it's sort of probably a bit of a follow-on regarding the AML at home patients. So these patients, the question was, do you transfer the patient for daily visits? So this is a separate cohort because they're actually still considered inpatients under haematology. So they're already on the ward. They've had their first dose, or their first cycle of intense chemo, what it might be, and then they're transferred to hospital in the home. So their location is hospital in the home, but their bed card still remains as haematology. And so that's how the transfer is done. And yes, daily or twice daily visits, which we're able to accommodate, we're able to do. Good question about virtual monitoring wearables. We are looking, our Liverwell program has done that excellently, but we haven't quite explored that just yet. There is a lot in terms of logistics with data and, you know, the privacy and who is going to action the information as it comes through. So that's something that we're looking at in the future. Thank you.
Perfect, fantastic. And there's a comment to, can we have more detail around nursing knowledge and accreditation management? And how do we do the general HITH nurse staff keep on top of the many pathways that are coming up?
We have a lot of procedures. We have a lot of education sessions. We utilise our educators a lot, and it's an ongoing challenge, and we're very aware of that. We have a very, very prescriptive what they need to do every year to maintain their competencies. And if anyone wants any details, I'm very happy. I've popped my phone number in the chat. Give me a ring and we can organise a time to chat.
Fantastic. The next question is to the broader team. Is anyone at Monash using remote monitoring devices with the patients?
Not currently. There are some other team units within the Monash community that started to look at clinical remote monitoring. So we hope to piggyback their experience. And so I guess it is definitely in our scope. And we think we are starting to identify some suitable cohorts to use clinical remote monitoring. We don't see it as a be and all to our services, but we are starting to tease out some niche subsets, and then looking at the experience of another team currently that sits within Monash community.
Fantastic. And how do the team manages the home visits, e.g. treatment times and travel time, if the group of HITH patients live quite diverse geographically?
That is our forever challenge we have yet to have come to a good solution with. We've tried a couple of different scheduling and logistics systems and as yet have not come up with the answer. If anyone knows one, please let me know. We currently run off Excel spreadsheets and some coordinators who do magic that I can't even begin to imagine. But we try and see the patients closer from teams closest to where they live. Of course, that is also dependent on if compounding pharmacy is near where they are, because that's not at all our sites either. It's a lot of work, and it's done surprisingly well for a lot of patients by magicians.
That's fantastic. The next one is a bit more political, which is definition of HITH. What is June's thoughts on the definition involving, and does it currently include reducing readmissions?
I've put in my bit, but I might just put the question to the panel, and I think everyone's been in the business of HITH. Yeah.
I mean, Victoria have a hospital avoidance program that sits separate to HITH, which I know not all states do. And that work in, I know some states does sit under the HITH banner, but we have a separate one that's called Hospital Admission Risk Program. And they support chronic disease patients and complex psychosocial patients for sort of 3 to 6 months and help do a lot of care coordination for them, and also, you know, teach self-management and link them into community supports. And so that sits outside of us, but for us, like we do a program with the acute on chronic liver disease patients. We do a 4-week program where, you know, at the moment they would get admitted to a ward bed to receive it. It could be done within the hospital admission risk program potentially in the future. We've done a lot of research and a lot of work around that. It's a group of patients that within 30 days have a 30% mortality rate if they're just left to be. We have about a 5% mortality rate. So it makes a huge difference to these people. You could argue acute, subacute if you wish to. We just want to make sure that the people we're lucky to provide care for get the best care that we can. And if we can find a way under the rules to see them, we will.
I think just to add to that, you know, one of the things about that hospital avoidance is, you know, all HITH programs are capacity limited to some extent. And, you know, it's about, to some extent, putting our HITH program where, you know, our capacity is going to be best used. And, you know, if we can clear out acute beds in the hospital and make room, you know, for more patients to physically get into the hospital, you know, that's probably a very efficient use if we're limiting capacity. Obviously, if we've got more capacity to do hospital avoidance, that has a secondary benefit, but not quite the immediate benefit of clearing beds.
Fantastic. And that seems to be all of the questions. There's some discussions in the chat in regards to the different solutions that are being worked on or exist for routing. I can tell that I came across a couple as well. One is actually from Barcelona, which has been used already by one of the pediatric HITHs over there quite successfully. I know that some companies locally are now starting to look into it as well as some of our HIT doctors have been looking at creating their solutions. So it'll be fantastic. Maybe in the future we'll have a grand round on it and different hospitals will present their solution and how it works. But until now, we're all going to try and do our best. And as Ellen said, magic. Excellent. Thank you, everyone. Really, really appreciate your time from the Monash team as well as the people attending, and hopefully got something out of it. And have a beautiful day. For those who are going to the World Conference, we'll see you in Vienna. And those who are not, we'll see you in the next grand rounds.